This PowerPoint is going to cover liver, biliary tract, and pancreatic problems. Hepatitis is inflammation of the liver. We have some causes here: viral, alcohol, medications, chemical, autoimmune diseases, and metabolic problems can all cause hepatitis. Hepatitis A can range from mild to acute liver failure, does not seem to be chronic, and the incidence has been decreased with vaccination. It routinely comes from contaminated food or drinking water. People tend to have like mild flu-like symptoms, and poor hygiene and proper handling of food, crowded situations, and poor sanitary factors are contributing to people developing hepatitis A. Hepatitis B can also be acute or chronic disease. The incidence has been decreased significantly with vaccination. It is transmitted perinatally, percutaneously, or via small cuts on mucosal surfaces and exposure to infectious blood, blood products, and any other bodily fluids. The majority of those infected with hepatitis B completely resolve. People at risk for hepatitis B are men who have sex with men, household contact of chronically infected patients, patients that are on hemodialysis, healthcare, public safety workers, any IV drug users, or people that are recipients of blood products. With hepatitis C, many patients are asymptomatic and unaware that they have an infection. However, chronic liver damage and cirrhosis can develop with chronic hepatitis C. And it is transmitted via IV drug use, high-risk sexual behaviors, occupational exposures, perinatal exposure, and then blood transfusions before 1992. About 30 to 40% of HIV patients are known to have hepatitis C, and there's an increased risk for hepatitis C in the age brackets from anyone born from 1945 to 1965. So that is important if you're going to be working in offices or where they're screening adult patients, because that has been known to be prevalent in that age group. So I have listed hepatitis D and E. I did leave these slides here, but for the purposes of this course, you will only be tested on hepatitis A, B, and C. So again, I've left hepatitis D and E on these slides. However, you are only going to be tested on hepatitis A, B, and C. So hepatitis D is also called Delta virus. There is no vaccine. It is a defective single-stranded RNA virus. However, there is some thought that if you are vaccinated with hepatitis B, it does decrease this risk. Hepatitis E occurs primarily in developing countries. There are very few cases in the United States. I have listed here India, Asia, Mexico, and Africa tend to have problems with hepatitis E. It is transmitted via the fecal oral route, and the common cause is usually contaminated drinking water. With an acute infection of hepatitis, large number of hepatocytes can be destroyed. However, the liver cells can eventually regenerate and the infection can resolve. With chronic infection, though, you can sometimes end up with fibrosis, which could then progress to cirrhosis of the liver. Some of your systemic manifestations include a rash, angioedema, angioedema is swelling beneath the skin of the lips, eyes, face. It could also be laryngeal swelling, arthritis, fever, malaise. Cryoglobulinemia is a form of vasculitis. It's abnormal protein that accumulates in the blood. And then I have glomerulonephritis here, which is an acute inflammation of the kidney. Table 43-2 in your book looks at the manifestations of hepatitis, and it is acute versus chronic. So many patients, again, are asymptomatic. Symptoms that could occur here are listed: anorexia, malaise, fatigue, lethargy. Patients can also experience weakness, a lot of arthralgias, and right upper quadrant tenderness. The acute phase can last anywhere from 1 to 6 months, and symptoms might be nausea, vomiting, right upper quadrant tenderness, reduced sense of smell. Patients may find the food repugnant, and distaste for cigarettes can occur. During the acute phase, you could also find hepatomegalia and splenomegalia, which is enlarged liver and spleen, and lymphadenopathy, which is enlarged lymph nodes. A patient can appear jaundiced, which is called icteric, and anicteric, which just means the patient is not jaundiced. If the patient is jaundiced, they can have some dark urine that is due to the increase in the bilirubin. They could have light or clay-colored stools as the bilirubin can't flow out of the liver. And pruritus, which is itching, happens due to the accumulation of bile salts. The convalescent phase begins as jaundice is disappearing, and this also has a variable time frame from weeks to months. The major problems here for the patient are malaise and easy fatigability. So these are two things that are very difficult to measure in your patients, so you have to, really assess that. Sometimes the patients just don't feel good, but fatigue is something that's kind of hard to assess. But many of these patients will complain of malaise and fatigability. Also, you might have that enlarged liver and spleen that could continue. The good news is many patients with hepatitis recover completely and have no complications. Most cases of acute hepatitis A do resolve. However, some hepatitis B and C can result in chronic hepatitis. Some of the complications here could be acute liver failure, chronic hepatitis, cirrhosis, hepatic encephalopathy, portal hypertension, ascites, and or liver cancer. Now we are going to discuss cirrhosis, hepatic encephalopathy, portal hypertension, and ascites later in this PowerPoint. Diagnostic studies can include specific antigen or antibodies for each type of the hepatitis, liver function tests. So what happens with liver function tests is that you'd want to look at the AST, the ALT, the bilirubin, and the alkaline phosphatase. Again, that's AST, ALT, bilirubin, and alkaline phosphatase. These can all be elevated in this patient. Your prothrombin time due to bleeding, your prothrombin time, your PT, which gives you your INR, that could also be elevated. And then your albumin level could be normal or decreased. You might also do some viral genotype testing, and this is for drug therapy. You're going to look at the physical assessment findings that we've already discussed. Patients could have a liver biopsy done. They could have what we call a fibroscan, which is used to assess stiffness of the liver. It is not invasive. And then the FibroSure is a serum test to assess fibrosis. So for both acute and chronic, you would want adequate nutrition, a well-balanced diet, perhaps some vitamin supplements. You're going to have to assess the patient's fatigue and looking at rest, and they're going to have to plan accordingly, according to how much fatigue they are feeling. Avoid alcohol intake and drugs that are detoxified by the liver. That is very important. Many of our drugs that patients take, usually you have to assess renal and liver function. And notification of possible contacts. You would want them on a high calorie, high carb diet if possible, along with frequent rest periods. So for hepatitis A and B, there really isn't a drug therapy that is prescribed. With hepatitis C, however, we have what we call our DAAs, which are direct-acting antivirals. And that can be found, more information on that can be found in table 43-7 in your book. And this is effective sometimes for treating patients with hepatitis C. You also have some supportive drugs based on their symptoms that you might be able to use. I just would like you to know that for the purposes of testing, I am not requiring you to know what drugs are given for hepatitis patients. Here's more information on nutritional therapy. No special diet is needed. However, emphasis on well-balanced diet that the patient can tolerate is important. Adequate calories is really important, and you might need to have them reduce their fat content. You might need some supplemental vitamin therapy, and sometimes these patients actually need IV glucose or enteral nutrition. It really does depend on the patient and their symptoms. The nursing assessment for hepatitis is covered in table 43-8 in your book. You'd want to look at the subjective data and do a history with these patients to see if there was drug and alcohol abuse. Are they a smoker? Any high-risk sexual behaviors? What is their weight? Have they experienced any nausea, vomiting, anorexia? Things like that. And then maybe doing a urine and stool assessment, along with assessing them for fatigue, arthralgias, and myalgias, and are they in a high risk group for exposure. Most of this nursing assessment for the objective data we've already covered, except for the low-grade fever. This is something that should be monitored in these patients. The rest of these items we've already discussed. Preventative measures for hepatitis is covered on table 43-9 in your book. And if you're looking at health promotion for hepatitis A, personal and environmental hygiene is important, as well as immunization. Children at 1 year of age are immunized, as well as adults at risk. And also there is post-exposure prophylaxis and special precautions for healthcare personnel. With hepatitis B, you want to identify those who are at risk and vaccinate. And again, immunization is a series of 3 injections, all children and at-risk adults. And there's also post-exposure prophylaxis for hepatitis B patients. The information regarding hepatitis C does continue to change. There were quite a few updates in this new version of the text compared to the last version. We are continuing to screen all persons born between 1945 and 1965, like I had mentioned before. There is not a vaccine currently to prevent hepatitis C, and there is no post-exposure prophylaxis. Baseline and follow-up testing is required. And infection control measures can modify and help prevent spread of hepatitis C. Screening of all blood, organ, and tissue donors is also required. So all hepatitis patients you want to assess as individuals. You want to look at their symptoms, how they're doing, and then maintain food and fluid intake adequate to meet their nutritional needs. And that could be different for all patients. They should avoid alcohol and hepatotoxic drugs, and hopefully they will show a gradual increase in activity tolerance. People should be able to perform daily activities, and they might need to have scheduled rest periods. Again, I cannot emphasize enough that you need to look at each patient with hepatitis as an individual, look at their symptoms, because they can vary significantly. We are now going to cover cirrhosis. Cirrhosis is described as end-stage liver disease. It's extensive degeneration and destruction of the liver cells. It results in replacement of the tissue with fibrous nodules. Usually can happen decades after chronic liver disease, and we have such a thing called biliary cirrhosis. And primary biliary cirrhosis is chronic disease of the bile ducts of the liver. And then we have primary sclerosing cholangitis, which is chronic inflammation and fibrosis of the strictures of the large bile ducts. We have cardiac cirrhosis, which results from long-standing severe right-sided heart failure. and it can cause hepatic venous congestion and fibrosis as well. There are few symptoms in early stage cirrhosis disease. However, fatigue and an enlarged liver may be early symptoms. Blood tests could also be normal, which means that the patient would then have compensated cirrhosis. Late manifestations result from liver failure and portal hypertension. The patient could be jaundiced, have peripheral edema, ascites, a lot of skin lesions, hematologic, endocrine, and peripheral problems can occur, and the liver does become smaller and nodule. You have to link cirrhosis to excessive alcohol intake because that is something that we tend to see. There are also two other things. It's called NASH, capital N-A-S-H, which is non-alcoholic steatohepatitis, and NAFLD, which is non-alcoholic fatty liver disease. And this could possibly be caused by malnutrition or genetic predisposition. So NASH and NAFLD can also occur, but often, many times, cirrhosis is caused from excessive drinking. There is also, with hepatitis, 25% of patients with hepatitis B can develop cirrhosis, and 20% of patients with hepatitis C can develop cirrhosis. So there are some other causes as well. This chart is also located in your book, and it does a nice job of explaining the pathophysiology of cirrhosis, from the inflammation to the necrosis. This figure does a nice job of explaining the clinical manifestations of cirrhosis. It is also found in your book. There is one thing here under integumentary. It's called caput medusae, and that is a ring of varices around the umbilicus. Caput medusae is a ring of varices around the umbilicus. And the rest of these you should be able to know what they are. Might want to go ahead and take a look at these. Now we're going to specifically go through some of the manifestations of cirrhosis. So the patient's going to be jaundice, and this results from a decreased ability to conjugate and excrete bilirubin. The connective tissue can become overgrown in the liver, and it compresses the bile ducts, which can lead to an obstruction and increase in bilirubin in the vascular system. Could be minimal to severe. You would want to draw bilirubin levels and assess that patient for jaundice. You could also have some skin lesions, and this is due to the circulating estrogen and the inability of the liver to metabolize steroid hormones. You could have spider angiomas, which are small dilated blood vessels with bright red center points. They look like spider-like branches. They can occur on the nose, cheeks, and upper trunk of the neck and shoulders. And palmar erythema, which is a red area that blanches with pressure. Patients with cirrhosis are very much at risk for hematologic disorders, and you have to be able to link a patient with liver dysfunction to a bleeding tendency. So we always want to be carefully looking for bleeding dyscrasias in a patient that has cirrhosis. So thrombocytopenia is a low platelet count, leukopenia is a low white count, and anemia is a low H&H. So those three together would be called pancytopenia. When you draw a CBC, you're assessing all three of those, and if they're all low, it would be called pancytopenia. And this could result due to the splenomegaly, the enlarged spleen, the coagulation disorders, again from the liver and the ability to produce prothrombin. So that's why some of these coagulation disorders occur. So you're going to have to draw a CBC on these patients. You're also going to have to draw a PT and a PTT, which is your clotting times. Those would be important. And then if you drew electrolytes, you would have your liver function tests on there. You also have to be on the lookout for endocrine disorders, and this is secondary to decreased metabolism of hormones. In men, there could be gynecomastia, loss of axillary or pubic hair, testicular atrophy, impotence, or loss of libido. And in women, you could have amenorrhea or vaginal bleeding. And you could have hyperaldosteronism in both sexes. And this is due to the liver failing to metabolize aldosterone. Peripheral neuropathy is a common finding in alcoholic cirrhosis. Usually results from dietary deficiencies in thiamine, folic acid, and cobalamin, which is B12. Patient may also experience sensory and motor symptoms. The patient could have compensated cirrhosis or decompensated cirrhosis. Decompensated cirrhosis means that the patient has one or more complications. We have some of these listed here, such as portal hypertension, esophageal or gastric varices, peripheral edema, ascites, hepatic encephalopathy, and hepatorenal syndrome. These are going to be discussed on the upcoming slides. Portal hypertension is the increased venous pressure in the portal circulation. This could also cause splenomegalia, large collateral veins, ascites, and gastric and esophageal varices. The collateral circulation develops in an attempt to decrease the high portal pressure and the increased plasma volume and lymphatic flow. So that's why you end up with large collateral veins. You also have esophageal varices. So these are tortuous enlarged veins at the lower end of the esophagus. And they also result from the portal hypertension. And then the gastric varices are the upper part of the stomach. Both are very fragile and bleed easily and could have the patient suffer from life-threatening complications if they bleed and rupture. With peripheral edema, you have a decreased colloid oncotic pressure from impaired liver synthesis of albumin, increased portocaval pressure from portal hypertension, and the peripheral edema occurs in the lower extremities and presacral area. Patients that have pitting edema will have a low albumin level. With ascites, it's an accumulation of serous fluid in the peritoneal or abdominal cavity. So a patient with ascites has a very, very taut abdomen. It's very, very large, and it's so tight that you're unable to pinch skin, and it does impair patients' breathing because the belly is so big. So the ascites forms due to a couple reasons. Could be formed from the portal hypertension. Also could be from a low albumin level. The albumin level is low because the liver has a decreased ability to synthesize albumin. And then hyperaldosteronism is when the aldosterone is metabolized by a damaged liver, it leads to water retention. You have a table 43-10 in your book that identifies factors involved in ascites. Hepatic encephalopathy can occur with patients with cirrhosis. You need to be able to link hepatic encephalopathy with a patient's ammonia level. What happens is the patient suffers from neurotoxic effects of ammonia, and it is an abnormal neurotransmission. The patient develops a decreased brain function, and they have this buildup of toxins due to the high ammonia level. So what happens is the ammonia ends up crossing the blood-brain barrier, and the patient can have significant changes in their level of consciousness. They can have totally inappropriate behavior. They could have sleep disturbances. Patients can fall. They can be very combative and throwing things across the room, actually hitting workers, and stuff that's very, very out of character for the family members to witness. So this is very, very concerning. There's a grading scale for encephalopathy that's in your book on 43-12, it's 0 to 4. I don't necessarily need you to know that and be able to put a patient on a scale. I would know that 4 is the worst though, and know that the level of consciousness can range anywhere from confusion to totally being unresponsive. The only things that raise your ammonia level are hepatic encephalopathy and seizures. So that's another thing to know. The liver is unable to convert any increased ammonia to urea, and that leads to a systemic rise in your ammonia level. So the ammonia level is another thing that you want to make sure it's not drawn on every single panel, doesn't come on an electrolyte panel. So this is something that somebody has to specifically draw if they're looking for a change in a level of consciousness in a patient. Anybody with liver disease would be important. There are some specific things you're going to look for in a patient with hepatic encephalopathy. Asterix is flapping tremors, most common in the arms and hands. It's when the wrist is extended and it resembles almost like a bird flapping. The patient with hepatic encephalopathy and a high ammonia level is going to have difficulty with writing and impairment of writing. They're not going to be able to write their name. It's going to be very messy. Their signature is not going to look the same. And so you'd want to always make sure to assess for that. Apraxia is the loss of the ability to execute or carry out a purposeful learned movement. Apraxia is the loss of ability to execute or carry out a purposeful movement, such as an example of this would be to brush your teeth. Like everybody knows how to brush their teeth, but you would hand this patient toothpaste, toothbrush, a cup of water, and they just look at you like they don't know what to do. Same thing if you handed them a comb or a brush, they don't know to comb their hair with it. So that is apraxia. Factor hepaticus is a musty, sweet odor of the patient's breath. It's a very distinct odor, and you will smell this if the patient does have a high ammonia level. It's from accumulation of digestive byproducts that the liver is unable to degrade. And then there is a chart, table 43-11 in your book, factors precipitating hepatic encephalopathy, which could be helpful for you to take a look at. Hepatorenal syndrome could also happen with a patient with cirrhosis. This is renal failure with azotemia. Azotemia are high levels of nitrogen. Oliguria, which is low urine output, and intractable ascites, which is that fluid in your abdomen. There's no structural abnormalities of the kidneys. However, the portal hypertension leads to vasodilatation, which leads then to renal vasoconstriction. And unfortunately, after you have the renal vasoconstriction, the patient does end up usually with the development of renal failure with advanced liver disease. And the only way to treat this is with liver transplantation. Pretty significant renal issues with a patient that has liver disease. Now we're looking at diagnostic studies and tests for the patient that has cirrhosis. So liver enzymes, these are going to be elevated. The alkaline phosphatase, AST, ALT, and GGT would all be elevated. Your protein and albumin levels would be decreased. Your serum, bilirubin, and globulin levels would be increased. Your cholesterol levels will be decreased. Your prothrombin time, which is your PT, and your INR are both going to be elevated. And then you could do a fibroscan to look at the elasticity of the liver. And then you could also do a liver biopsy, which is analysis of the acidic fluid. That could help also to confirm the cause, along with a biopsy of the liver. So what we're going to do with a patient that has ascites is usually they're put on a sodium restriction. So you're going to limit the amount of sodium that they intake. And then you're going to look at perhaps giving some diuretics. Some of the diuretics we have listed here are spironolactone, which is aldactone. And that is an antagonist of aldosterone and is potassium sparing. That's spironolactone, aldactone. And then sometimes patients are also just given loop diuretics such as furosemide or Lasix. Patient might be given albumin. Samsca is given for hyponatremia. Paracentesis would be a needle drainage to alleviate the acidic fluid. We'll talk more about that in some of the other future slides, but unfortunately what happens is the paracentesis, if you remove the fluid with the ascites, the fluid comes right back. The TIPS is also could be done. That's putting in a shunt there. And that would only happen if the shunts would only happen if we couldn't get the patient to respond to the diuretics and the other mechanisms that we're trying. The varices a patient may have could lead to bleeding or hemorrhage. You would want this patient to avoid alcohol, aspirin, and L-NSAIDs. The patient could have an endoscopy to look for these varices. Sometimes they are put on beta blockers, such as Corgard or Inderol. Corgard, the other name for that is Nadolol, and Inderol is propanol. And then if the bleeding occurs, you want to stabilize the patient, maintain airway, start IV therapy, and blood products. Some of these patients can lose an awful lot of blood if the bleeding starts, so you'd have to implement emergency measures. Other drug therapy that we can try here is octreotide. The other name for that is sandostatin, and then vasopressin, which is pitressin. Vasopressin is pitressin. Those drugs are routinely used for GI bleeding. And then if you were looking at doing sclerotherapy, that is injection of an irritant that causes inflammation, and therefore it coagulates the blood vessel. The beta blockers are good for increasing the portal pressure, and vasopressin is usually used to decrease chances of hemorrhaging. I also have two things listed here: melena, which is MELENA, which is black tarry stools, which you might see in the patients that are bleeding, and then hematemesis, HEMATEMESIS, is vomiting of blood. You might see either of those. If a patient is actively bleeding, they might suggest a balloon tamponade. This is where a tube is inserted and a balloon is inflated, and that mechanically compresses the varices and hopefully makes the bleeding stop. We have a couple different types of tubes here, and I don't necessarily need you to know the difference between these, which tube you would select. These are routinely used for patients that are bleeding, though, so it might be a good idea that you could recognize these names of these tubes, had they ever, if they ever appear on your NCLEX exam or something like that, that they are used for, compressing the varices. But I will not ask you per se the difference between these tubes. If somebody's actively bleeding, we would require them to have FFP, which is fresh frozen plasma, and packed red blood cells. You may also administer vitamin K for clotting. And the proton pump inhibitors would be a medication called Protonix, PROTONIX. And then the lactulose and rifaximin are going to be given for the patient with a high ammonia level. So that would be your hepatic encephalopathy. And then the antibiotics, actually the rifaximin and the Xifaxan, those are actually antibiotics. The long-term management of the patient with cirrhosis is going to vary based on the patient problems and what their complications are. However, many patients might be put on beta blockers, and they might have some of the shunting procedures that are done. The specific goal for a patient with hepatic encephalopathy is to reduce the ammonia level in the patient. There's a couple different medications. Lactulose is an oral medication which traps ammonia in the gut, and the patient then has a lot of different stools that is going to excrete the ammonia in the stool. However, it is key that you prevent constipation in any patient that has hepatic encephalopathy, as that is going to raise their ammonia level. So preventing constipation, making sure the patient is having frequent bowel movements is going to be helpful. Many patients are given lactulose, and it takes a while or a couple of days for that to work and to bring that ammonia level down. So we also have a medication called rifaximin, which it can be given IV or PO, and it is an antibiotic. However, that does work well to lower a patient's ammonia level, and sometimes it might be a little bit quicker, especially if we can give it in the IV form. Other options for lowering the ammonia level is going to be to look at the dietary protein, lowering that protein intake. That's very, very hard though, because sometimes patients are starving because, if you lower protein levels too much, the patient doesn't feel like they're able to eat hardly anything. You want to make sure you're controlling bleeding and removing blood from the GI tract, as that can also raise ammonia level. And then drug therapy is really not specific for cirrhosis. There's several drugs that we use. What we do with patients with cirrhosis is we treat the symptoms and the complications of their advanced liver disease. So you do need to know lactulose and rifaximin are your two medications that would treat a high ammonia level in a patient with cirrhosis. So for a patient that did not have any of the complications, you would want a high-calorie diet, high carbohydrate, moderate to low fat, and the protein restriction would rarely be needed. That would only be used for the patients with hepatic encephalopathy. You might want to look at protein supplements, a low-sodium diet if the patient did have some ascites or edema, and collaborate with a dietitian. That could always be helpful. So there are two charts, table 43-13, which looks at interprofessional care of the patient with cirrhosis, and the nursing assessment, which is table 43-15. Some of the things you'd want to look at is the past health history and medications that the patient could be on that could make a difference. Here's a list of some of the subjective data that you might want to be on the lookout for. You'd want to do a good assessment of the patient's alcohol use. Also looking and monitoring weight. Does the patient have GI symptoms? Is there bleeding anywhere? What's the I&O? What do the stools look like? And sending some stool samples might be helpful. Is there bruising? Is the patient having itching? Those types of things. All this, you would need a good history on this patient. The next couple slides are a comprehensive list of your objective data. I left this all here so that you could take a look at it. It is, again, looking at the edema. It's looking for bleeding, jaundice, abdominal distension, ascites, any abnormal bleeding. So they're all listed here. Here's more objective data on these next couple slides. This slide lists some of the lab tests that you might see. So how we're going to care for the patient with cirrhosis is important. Your acute care, you're going to monitor the color of urine and stools. Remember, stools are important here. Have an accurate I&O. Daily weights, make sure they're accurate, make sure they're done consistently. Looking at extremities measurements, how big is the abdominal girth if we're having to measure for ascites. What are you going to do to relieve the itching? Cholestyramine is used often. Sometimes we can have baking soda and alpha caribas. Those can be very, very helpful. The pruritus with some of these patients is pretty uncomfortable for them. You want to also be monitoring their level of consciousness, their motor coordination, again, due to those altered ammonia levels, perhaps. So a neuro assessment should be done if anybody does have hepatic encephalopathy every 2 hours. And you'd also want to make sure that we are preventing constipation in those patients with hepatic encephalopathy. So paracentesis is the drainage of the acidic fluid in a patient's abdomen. You'd always want to make sure that you have the patient void immediately before. You'd want them in either high Fowler's position or sitting on the side of the bed. You'd want to monitor for hypovolemia and electrolyte imbalances, as well as monitor blood pressure and heart rate once the fluid is taken off. The dressing actually can sometimes bleed or leak a little bit. And what happens is the patient can have a paracentesis done, and it does help with their breathing. This sometimes has to be done every other day, things like that, because what happens is you can take off 2 liters of fluid and then before you know it, it comes right back. The reason we do this is because dyspnea is a frequent problem for patients with severe ascites, and they really can't breathe. So what happens is by doing the paracentesis, we know the fluid's probably going to come back, but we also know that that'll make them feel like they can breathe a little bit better. You'd want to also do fluid restrictions on patients that need paracentesis, usually less than 1,500 mLs per day. You want to measure their girth every day, measure their abdominal girth, and make sure that you have accurate weights on these patients. Here are some further implementation guidelines looking at making sure the patient's in semi or high Fowler's position for relief of dyspnea. Perhaps skin care, looking at special mattresses, turning schedules, making sure the patient has range of motion exercises, coughing and deep breathing exercises, and then elevating the lower extremities and scrotal area if there is edema in those areas. Here's a question. A patient with advanced cirrhosis who has ascites is short of breath and has an increased respiratory rate. What should the nurse do? The correct answer here is D. Place the patient in Fowler's position to relieve pressure on the diaphragm. Here's some additional information on the acute care of the patient with hepatic encephalopathy. Remember, that is the high ammonia level. Making sure the patient is safe is a priority. You're going to need to assess carefully the level of consciousness, the sensory and motor abnormalities, perhaps acid-base imbalances, how they're responding to treatment measures, what is their fluid and electrolyte status. They're going to need a neurostatus at least every 2 hours, making sure that they're not falling or being injured. Minimizing constipation is a must. Encouraging fluids and control factors that are known to precipitate the encephalopathy. That would all be very important. We are now going to talk about pancreatitis. Acute pancreatitis is an acute inflammation of the pancreas. You have spillage of pancreatic enzymes into the surrounding pancreatic tissue, which causes autodigestion and severe pain. It is very, very painful. It varies from mild edema to actually necrosis of the pancreas. The causes are alcoholism and biliary tract disease, usually. There is a link between gallbladder disease in women and pancreatitis and alcohol use in men with pancreatitis. Some other less common causes for drug reactions, corticosteroids. People can have pancreatic cancer. Hypertriglyceridemia is a level over 1,000, which is quite elevated. Trauma, if somebody has an injury to their pancreas. Certain drugs, such as thiazide diuretics, oral contraceptives, or NSAIDs, could also be a cause. There is an injury to the pancreatic cells and activation of pancreatic enzymes, which cause autodigestion of the pancreas. The activation of trypsinogen to trypsin within the pancreas can lead to bleeding. And alcohol is, like we said before, a common cause. However, the exact mechanism is not known. Alcohol may increase the production of pancreatic enzymes. This map here identifies the pathophysiology of pancreatitis. Lists your factors here, which we had already mentioned. The older book used to also list smoking as a factor. And I noticed that this book does not list it any longer. So if you have the older version of the book, it used to list smoking, and we don't send to, it does not appear to be listed in this newer version of the book. That was always thought to be a relating factor to the people that developed pancreatitis, was if they were smokers or not. There are levels of pancreatitis. You could have mild or you could have severe. Severe pancreatitis can be necrotizing. It can cause organ failure, sepsis. You could have endocrine and exocrine dysfunction. The overall fatality rate is about 5%, which has decreased significantly over the past years. Abdominal pain is going to be a predominant manifestation with these patients. It usually is left upper quadrant or mid-epigastric, can radiate to the back, does come on suddenly. It is a deep, piercing, continuous, or steady pain. You might want to highlight here it's eating worsens the pain. So that's pretty significant with these patients. And it's not relieved with vomiting. So you might want to highlight that too. So anytime they eat, their pain gets worse, and it's not relieved with vomiting. So those are some signs that we look for, and when patients, come and they report these symptoms, we would think of pancreatitis. Other things that you could identify here is some flushing of the skin. They might have some cyanosis, and that could be the greenish to yellow-brown discoloration on the abdominal wall. You might see that. There's just areas of cyanosis sometimes on the abdominal wall. And then they might have nausea, vomiting, and they could also present with a low-grade fever. Additional manifestations you might see is leukocytosis, which is an elevated white blood cell, hypotension or tachycardia, and there could be hypovolemia due to a fluid shift into the retroperitoneal space. The patients could be jaundice. They're going to have significant abdominal tenderness and guarding if you try to examine them. Decreased or absent bowel sounds. If they were completely absent, the patient would have an ileus, but a lot of times they are decreased. Again, their pain worsens with eating, so by the time they end up in the emergency room, they usually have, not eaten for quite some time. What you might see or hear are crackles in the lungs. On the previous slide, it had also said dyspnea. So you really want to be able to link respiratory issues. We'll talk about that a little bit further on a different slide, but respiratory issues and relate those to pancreatitis. Many of your patients with pancreatitis could end up with some respiratory issues. Abdominal skin discolorization, we have gray Turner's spots or signs, which is ecchymosis on the flank area of the body. Ecchymosis on the flank, so bruising. You have Cullen sign, which is a bluish peri-umbilical discolorization. Cullen sign is a bluish peri-umbilical discolorization. And then the patient could also have the hypotension could increase to shock, and then you would have to give some vasoactive drugs to raise that blood pressure, or some plasma or plasma extenders to this patient. A complication could be a pseudocyst, which is a fluid pancreatic enzymes debris and exudates surrounded by a wall. It might be the patient would complain of abdominal pain. There might be a palpable mass. It usually is detected with imaging, and it could resolve spontaneously or might need some surgical drainage. The patient could also have a pancreatic abscess, which is an infected pseudocyst, and this results from extensive necrosis that could rupture or perforate, and it usually needs prompt surgical drainage. And this patient might present with significant abdominal pain, a high fever, and leukocytosis. So like I had mentioned before, the lungs are frequently involved in a patient with acute pancreatitis. It is likely due to the inflammation of the diaphragm. So you want to always be on the lookout for pulmonary complications. The patient could have a pleural effusion, some atelectasis, pneumonia, ARDS, which is adult respiratory distress syndrome. And so what happens is this patient might come in and their oxygen level might be fine for even 24 hours, and all of a sudden they might feel short of breath and they might feel like they're having difficulty breathing. So you always want to be on the lookout for this. You want to assess respiratory status on a patient with acute pancreatitis admitted to the hospital several times throughout your shift. So at least every 2 to 3 hours, you'd want to go in and do another reassessment of the oxygen level. Patient could also have some hypotension. The patient could develop a thrombi, a clot, which then if that dislodges, that could lead to a pulmonary embolism. And DIC is disseminated intravascular coagulation. That is a significant bleeding disorder that sometimes ends in death. People start to bleed from every orifice that they have, and it can be fatal. That is covered extensively in Nursing 104. And then the other thing that you want to highlight here is hypocalcemia. So we had said with pancreatitis, you always want to identify that pulmonary and be on the lookout for pulmonary. You also want to make that link between calcium level, assessing a calcium level, and your patient with pancreatitis. So the patient can end up with a very low calcium level, and then you'd also want to be on the lookout here for the Trousseau's and the Chvostek sign, which we had covered when we talked about the calcium. The Trousseau's is with the blood pressure cuff, and the Chvostek's is when you tap on their facial nerve. So you want to be on the lookout for that. They might need to be treated with IV calcium. So regarding the laboratory tests for a patient with acute pancreatitis, you want to highlight the amylase and lipase levels. These are very important. You have to be able to link amylase and lipase to pancreatitis. So what happens is when this patient comes into the ER or to a doctor's office and they get sent for testing or whatever, and a patient has acute abdominal pain, one of the levels that they're going to draw are the amylase and the lipase levels, because you're looking to see either rule things in, rule things out. If these come back extremely elevated, this patient has pancreatitis. If they're normal, then they're normal. But if they're elevated, what happens is what we do is when we start to admit a patient to the hospital and then we start to treat them, we're going to look for those to trend downward over the next couple days. So usually the highest levels of your amylase and lipase are noted on admission. So those are both going to be elevated. Your liver enzymes, triglycerides, glucose level, and bilirubin level are also going to be elevated. And your serum calcium level is going to be low. So everything is elevated on this slide except for your serum calcium level, which is going to be low. Here are some diagnostic studies that can be done. You might do an ultrasound, you might do an x-ray. Sometimes a CT scan will be done, especially if the patient's in the ER and they come in complaining of abdominal pain. You could have an ERCP, an endoscopic ultrasound, an MRCP. They might do angiography, and they would probably most likely do a chest x-ray, at least for a baseline in this patient. One of your first objectives is going to be to provide relief of pain. This is extremely painful, so do not be stingy with pain medications in your patients with acute pancreatitis. Remember, it's autodigestion of your pancreas. It sounds painful. It is painful. You also are going to look at making sure that the patient does not have shock or go into shock. Have decreased pancreatic secretions. You're going to do this and accomplish this by making the patient NPO. Correct fluid and electrolyte imbalances, and prevent or treat any infections, and removal of precipitating cause if we can identify what caused this pancreatitis. So this is a key slide, so you might want to highlight this slide. You would need to know how we're going to care for this patient. We are going to provide aggressive hydration. So the patient is probably going to have been very uncomfortable for several days coming into the ER. They might not have been able to eat or drink anything because everything was agitating it. Their symptoms. So what you're going to have to do is provide probably some fluid boluses and then aggressive hydration. Pain management is definitely necessary. They're going to need IV pain medication. They're going to have a strict NPO status, so no oral medications could be allowed. You're going to manage metabolic complications. We need to assess the respiratory status, like we had already mentioned, really pay close attention to their oxygen status, and then also monitor glucose levels. You want to minimize pancreatic stimulation. Therefore, the patient has to be on a strict NPO status. They may or may not get an NG tube. Some doctors do, some doctors don't. You want to look at decreasing acid secretion. Enteral feeding may be needed, may not be. Usually the patients do pretty well if they are managed on a strict NPO status. They usually start to feel better within a couple of days, and then they'll go from there, and they usually do not need the enteral nutrition. So for drug therapy, we're going to look at IV morphine, which is an opioid, which should be given for the pain. Antispasmodics, there's a medication called Bentyl that decreases vagal stimulation. It's Bentyl. The other name for that is dicyclomine. Then there is carbonic anhydrase inhibitors. An example of that would be Diamox. The other name for that is acetazolamide, and this is actually thought to decrease some pancreatic secretions. Antacids could help. And then we also have the proton pump inhibitors, which would be like your Prilosec and your Protonix. And then for nutritional therapy, the patient has to be NPO status initially. Depending on how long they have to be NPO, we might have to look at enteral versus parenteral nutrition. A lot of the patients do get parenteral if they're not able to tolerate, anything oral. You want to monitor triglycerides and IV lipids if IV lipids are given, because again, they might already have elevated triglyceride levels. And then if you were starting to initiate feedings, you would want to do some small frequent feedings when you are able to do that. Here are the diagnostic findings listed again. We had already mentioned some of these before. Your nursing assessment for the patient with pancreatitis is on table 43-21 in your book. So for acute care, you're going to be monitoring vital signs frequently. You're going to be on the lookout for hypotension, fever, tachypnea. You want to closely monitor their respiratory function at all times. Monitor their response to IV fluids and looking at their fluid and electrolyte balance. You want to specifically look at the chloride, sodium, and potassium levels, as well as the calcium levels and your magnesium levels with these patients. Pain assessment is key, like we had mentioned before. You want to make sure the patient is in a position of comfort, and that might be side lying or drawing their knees up to their abdomen. You want to provide frequent oral nasal care, and that is to prevent inflammation of the parotid gland, which we would call parotitis. You want to administer antacids if appropriate. Observe for signs and symptoms of infection. Turn, cough, and deep breathe this patient. Again, respiratory assessments are key, making sure the patient's in a good position, such as semi-Fowler's. Observe for an ileus, renal failure, or mental changes. And then you want to monitor the glucose level. So pancreatitis damages the cells that produce insulin and glucagon. So pancreatitis can damage the cells that produce insulin and glucagon. Therefore, a patient with pancreatitis could have an elevated glucose level. So remember, if you're looking at pancreatitis, the patient's going to have extreme pain. They need to be medicated accordingly. You have to do good respiratory assessments and be on the lookout for them to have respiratory distress. You want to measure their calcium levels and their glucose levels frequently and monitor that. The nurse explains to a patient with an episode of acute pancreatitis that the most effective means of relieving pain by suppressing pancreatic secretions is the use of the correct answer here is NPO status. So now I have just a couple slides here on chronic pancreatitis, which is different than acute pancreatitis. So chronic is the prolonged inflammatory and fibrosing process of the pancreas. Some of the causes could be alcohol, gallstones, tumors, pseudocysts, trauma, autoimmune pancreatitis, cystic fibrosis. There are a couple different types. There's chronic obstructive and there's non-obstructive pancreatitis. I want you to know that a patient that has chronic pancreatitis may not have an elevated amylase and lipase. They could be slightly elevated, but they're probably not going to be consistently elevated over time. However, sometimes they will have an elevated bilirubin, alkaline phosphatase, and an elevated SED rate, which looks at inflammatory levels. So here's some more information on a patient with chronic pancreatitis. They may have abdominal pain, could be a gnawing, burning, cramp-like feeling. Should be in the same area of the patients with acute pancreatitis. And patients with acute pancreatitis can then lead into chronic pancreatitis. So sometimes some of these patients have problems that did not go away, such as with the trauma or things like that. Malabsorption with weight loss might be seen, some constipation, mild jaundice with dark urine, steatorrhea, which is that fatty, oily stools, diabetics due to the glucose issue that we had already talked about. And then what you want to do is highlight the creon here, which is pancreolipase. So this is really the only medication that's a pancreatic enzyme replacement. So if people have long-term chronic pancreatitis, they're going to have to take this medication every single time they eat. It's extremely expensive, and the patient, it's the only reason that the patient would be taking creon is if they needed pancreatic enzyme replacement. So what happens is they need it for breakfast, lunch, and dinner every single time that they take anything in their mouth to eat, that they're going to need this enzyme replacement. They just don't have enough of it, and without it, they're going to have significant symptoms. So with the patient with chronic pancreatitis, you do want to observe stools and monitor glucose. Many of these patients can end up with diabetes, like we had said. Again, chronic pancreatitis, the patient could still have quite a few symptoms, and it just might not resolve over time. We are now moving on to gallbladder disease. I have some definitions here for you. Cholelithiasis means that the patient has stones in their gallbladder, and cholecystitis is inflammation of the gallbladder. You do need to know both of those terms. Gallbladder disease is a very common health problem. Some of the risk factors would be female, multiparity, over 40 years old, estrogen, a sedentary lifestyle, family history, and obesity. Obesity causes an increase in secretion of cholesterol in the bile. It can also be related to extensive fasting, if people were fasting frequently, and also related to pregnancy. Sometimes you'll see that as well. Cholelithiasis can develop when the balance that keeps cholesterol, bile salt, and calcium in solution is changed, and that can lead to precipitation. Stasis of a bile leads to supersaturation and changes in composition. We call that biliary sludge. Immobility, pregnancy, and inflammatory or obstruction lesions of the biliary system can cause decreased bile flow. And stones may stay in the gallbladder, or they could migrate and get stuck in the cystic or common bile duct. And they can cause a lot of pain as they pass through the ducts. And they could also lodge in there and cause an obstruction. Cholecystitis, again, is inflammation of the gallbladder, and this is usually associated with obstruction from stones or sludge. However, this also can happen when there is no obstruction at all, and we would call that a calculous cholecystitis. It can occur in patients that are older and that are critically ill, prolonged immobility, fasting, or prolonged parenteral nutrition, and diabetes. So for example, when I used to work in the ICU, you'd see somebody that was on a vent for like several weeks or something like that. They weren't eating for a very long time. They were critically ill. And then that in and of itself, just not eating, not fasting, and not eating for a long enough period of time, or receiving the parenteral nutrition, could cause these these patients to develop gallbladder symptoms. Also could be caused from like a cancer, anesthesia, biliary stasis. There are some few common causes there. So with the inflammation, it could be confined to the mucus lining or it could encompass the entire wall. The gallbladder is edematous and hyperemic, which means there's increased blood flow. It could be distended with bile or pus. The cystic duct could become occluded, and scarring and fibrosis can occur. With gallbladder disease, the symptoms can vary from being very severe to no symptoms at all. The pain is going to be more severe if the stones are moving or obstructing. So these patients have steady, excruciating pain. They can become tachycardic, have diaphoresis or prostration, which is extreme weakness. They could have residual tenderness in the right upper quadrant, and this could all occur 3 to 6 hours after a high-fat meal when the patient lies down. If a total obstruction occurs, you may see these symptoms: dark amber urine, clay-colored stools, and that indicates a problem with the drainage of the biliary system. Pruritus, which is itching, and that is the itching causes from bile salts accumulate that cause the itching. Intolerance to fatty foods, obviously, because that's going to be their problem. They might have some bleeding tendencies, and then steatorrhea, which is the presence of the excess fat in the feces. It's like a oily, fatty appearance. And the patient could also perhaps exhibit fever and chills. Your nursing assessment for these patients is found on table 43-24 in your book. In addition to the pain, they might experience indigestion, fever and chills, like we had just mentioned, jaundice, nausea, vomiting, pain. And that pain can also be referred to the right shoulder, scapula area. They could be very restless, diaphoretic. There could also be signs of inflammation, such as leukocytosis and the fever, and they're going to have some guarding to that right upper quadrant on the physical exam. Complications of cholecystitis could be a gangrenous gallbladder, an abscess, pancreatitis. There is a link between pancreatitis and gallbladder disease. Sometimes they do go hand in hand, so you'd always want to be on the lookout for that. Cholangitis is inflammation of the bile ducts. Biliary cirrhosis is damage to the bile ducts in the liver. Fistulas could occur. The gallbladder could rupture, and that could lead to peritonitis. And choledocholithiasis is a stone in the common bile duct that produces symptoms of an obstruction. That is a stone in the common bile duct that produces symptoms of an obstruction. So there are some common things that you are going to use to identify if the patient has gallbladder disease. A gallbladder ultrasound can routinely be done pretty easily. There is an ERCP, which is an endoscopic retrograde cholangiopancreatography. It looks at the cystic duct, the pancreatic duct, the gallbladder, and the hepatic duct. So the ERCP can look at the cystic duct, the pancreatic duct, the gallbladder, and the hepatic duct. So it really can look at quite a few different things, and so this is sometimes very, very useful. The percutaneous transhepatic cholangiography is inserting a needle into the gallbladder duct and then injecting contrast materials. There's also laboratory tests here that show what would be routinely, they're all going to be elevated: a white blood cell count, the bilirubin in the serum and the urinary, and then elevated liver enzymes and elevated serum amylase could occur. The patient could have an ERCP with sphincterotomy, which means they're going to use this for stone removal. So the stones are removed with a basket. And then the patient could also have extracorporeal shockwave lithotripsy. And here the stones are broken up into fragments and they pass through the common ducts into the small intestine. You want to control for a possible infection, so sometimes patients are put on antibiotic treatment. Also, you might need an NG tube for severe nausea or vomiting. A cholecystotomy may be used to drain purulent material from an obstructed gallbladder. You would need opioids again for pain control. And then sometimes anticholinergics are used to counteract muscle spasms or to decrease GI secretions. So if it is determined that the patient's gallbladder is not working well, most patients would opt for a laparoscopic cholecystectomy. That is the laparoscopic removal of your gallbladder. If it can't be done laparoscopically, then they would have to have an open procedure. That is not as common as it used to be. Most patients can be treated successfully with a laparoscopic cholecystectomy. You remove the gallbladder from anywhere from 1 to 4 small puncture holes. They have minimal postoperative pain and they can resume their normal activities, and there's very few complications to this procedure. The open cholecystectomy obviously is a larger incision, and a patient would need usually to have a T-tube inserted into the common bile duct. So you may want to highlight T-tube. T-tubes drain bile. So if you're going to work in an ICU, you might see a T-tube. You're probably not going to see a T-tube on a med-surg floor. They used to be, all gallbladders used to be taken out the open way, so we used to see these all the time. But anybody that's a trauma might have a T-tube, things like that, if they had to go in there. So anybody with a common bile duct injury might have a T-tube inserted, and it actually is like just drains to a bag, and you can see it. It's like a dark green color of the bile. Here's a picture for you. I thought this was helpful. It shows the hepatic duct, where a T-tube would be, into the common bile duct, your pancreas, and where they would remove the gallbladder. The surgical treatment of choice for a patient with a symptomatic gallbladder disease is the correct answer here is laparoscopic cholecystectomy. So for drug therapy, analgesics, morphine is most common. For anticholinergics, atropine might be needed. Fat-soluble vitamins. And bile salts. Bile salts actually help digestion and vitamin absorption. Cholestyramine is also called Questron, Questron, and that may be given for itching. We had mentioned this before. It comes in a powdered form mixed with milk or juice. You want to monitor for side effects and check drug-to-drug interactions, but the Questron usually is quite effective for helping the itching with a lot of patients. So this should make sense to you. Abnormal diagnostic findings could include elevated serum liver enzymes, increased alkaline phosphatase, increased bilirubin levels. Sometimes patients actually appear quite jaundiced and they have gallbladder disease, so that is something that we do see a lot with these patients. Increased urinary bilirubin, leukocytosis, and abnormal gallbladder ultrasound findings. Postoperatively, a patient with an incisional cholecystectomy has splinted respiration secondary to a high abdominal incision. Which action should the nurse take first? The correct answer here is to administer the prescribed analgesic. Anybody that has an abdominal incision needs to be medicated effectively in order for them to be able to, breathe and oxygenate well. So administering the prescribed analgesic to somebody who has splinted respirations is appropriate. I wanted to mention one more thing about gallbladder surgery. And gallbladder surgery is done laparoscopically. Anybody who has laparoscopic surgery We talked about this when we talked about the section on surgery. They could end up with like some shoulder discomfort, some chest discomfort, and that usually is due to that air being trapped in there from the laparoscopic procedure. So getting any post-operative patient that's had laparoscopic surgery up and moving about will help decrease that shoulder discomfort. So that's just one more thing to note about a patient that has a laparoscopic cholecystectomy. Now with gallbladder cancer, this is often found incidentally. People go in to have a gallbladder removed and they find that it is cancer. Unfortunately, many have advanced disease at the time of diagnosis. If found early, surgery can cure this. But there tends to be a poor prognosis overall. But it is not something that is very common. It is, for how many people that have gallbladder disease, gallbladder cancer is relatively rare. And that concludes this PowerPoint.